Welcome back to theheart.org. My name is Professor Tony Gershlick. I'm from the University Hospital Leicester, UK, and I'm here in Munich ESC 2012, and I'm privileged to chat to some of the PIs of the hotline sessions and late breaking. And I'm delighted to have with me Matt Roe, who presented the TRILOGY-ACS data, which has created an enormous amount of discussion, heat and light, and hopefully over the next 5-6 minutes we'll drill down to some of the implications.
Okay.
So Matt, welcome, and just give us a little bit of background why the study was set up, a little bit of the methods and the results, and then we'll get into some of the nuances, or maybe the not nuances, of this trial, and how we can interpret it for the audience.
So we wanted to study first medically managed ACS patients who didn't undergo revascularization, who've never been studied exclusively before in a contemporary ACS trial. Most trials of ACS patients, 60 to 70% of the patients undergo revascularization. So we've done some previous analysis, and others have as well, to suggest these patients are prevalent and they have a much higher risk of patients who undergo revascularization, but they're quite heterogeneous, and I think most people would know that. So we also wanted to test whether intensified platelet inhibition with Prasugrel compared to the standard Clopidogrel, which is recommended for these patients, would improve their outcomes. And the previous study with Prasugrel was only in ACS patients who underwent PCI.
And the previous study in Clopidogrel suggested there was benefit in these medical managed
Yes.
patients. So there's a basis for
Yes.
looking at application of the more potent therapies in this patient population. You have quite a high risk in terms of adverse outcome.
We do, and we designed the trial in that way, and that is that we had some enrichment features from the GRACE risk score designed to enhance the risk, and knowing that these patients were ones who were not candidates for revascularization, the risk would be higher. Now you look at our event rates and compare them with similar time frames of other ACS trials, and they're higher.
Yeah,
certainly.
So we've just talked about this in the last day or so, and what are they high risk? The GRACE scores average of a mean of 114, I think.
Yeah.
So are they high risk? Are they medium risk? Are they low risk? Some people would say this is a low risk population, particularly in terms of the fact you've got an unstable angina subgroup in there of about 30-40%.
Well, I think the thing to mention about this trial, and we show this in the figure 2 of the manuscript, the unstable angina patients actually had a similar event rate as the non-STEMI patients. If you look at other studies done recently, typically the unstable angina patients have half the event rate of the non-STEMI patients. And I think it's how we designed the trial, because they had to have enrichment features such as diabetes, previous MI, previous revascularization, etc. So those actually, we took, and the unstable angina patients had to have definitive ST depression. So, obviously they're not the same as the non-STEMI patients, but I think the risk is higher than previous studies.
So people might look at this group and say they were a low-risk population. They might do that because they say, why would you apply a potent agent to a low-risk population? What you're contending is that they're not a low-risk population, they're a medium-risk population in whom it's quite valid to test a more potent, particularly if you think they're unstable angina and STEMI is a thrombotic event. So that was the basis.
Yes.
So how many patients?
So we enrolled 9,326 patients overall, but the trial was designed to test first in the younger patients less than 75 years of age, because most of those patients received the standard Prasugrel 10 milligram maintenance dose. We did reduce the dose to 5 milligrams for lightweight patients below 60 kilograms, and we also explored the 5 milligram dose of Prasugrel in elderly patients above the age of 75, but that was an exploratory analysis. The trial was not powered. So altogether there's around 9,300 patients, but 7,200 younger patients, about 2,100 older patients.
Okay, so most of the young patients, but I think if I remember from the paper, the overall populations are applicable to both groups.
Yes.
Okay,
Yes.
So we don't need to worry too much about that, and that will come out in separate papers. So tell us the results, because I think most people know the results, but tell us your spin on the results.
So as you know, there was in the first 12 months, there was no difference. The event curves were overlapped. Looking throughout the whole study, the effect on the primary endpoint was neutral. The p-value was 0.21, so we didn't meet our objectives, and we didn't show superiority. But we had a really intriguing finding that...
Just I'm going to stop you, because the audience will be very interested in this, because we both believe that these patients have an acute event or a worsening of their angina due to a thrombotic event. Prasugrel is more potent than Clopidogrel. You would have expected the Prasugrel patients to have done better in terms of ischemia.
Yes.
Tell us your thoughts, because I've got a chance to speak to you, the PI, your thoughts on why it was neutral.
So a couple of things. First is we enrolled patients typically 4 or 5 days after they presented. They didn't have a stent implanted, so maybe their disease had stabilized by this point. Almost all the patients were pre-treated with Clopidogrel per practice guidelines, and that may have stabilized the situation. And their response to increased platelet inhibition may not be the same as for someone who has a stent implanted, where we know implantation of a stent would augment your platelet reactivity.
So these are stabilized unstables.
Yes.
In a way.
Yes.
We've discussed this also. So these are stabilized patients, and they may have moved to a different category of patient as a result of their somewhat delayed initiation to randomization. So that's one answer.
Yes.
So, but we've got to get to this intriguing finding at 1 year, because looking at the data, it's well, tell us about it.
So we didn't expect this at all. It was a totally unique observation. I think because we followed patients for longer than 12 months, which is typically the ending time for other studies, we were able to make this observation. So is it related to the fact that new lesions are developing in different vessels and it takes some time to accrue that? Perhaps is it that patients basically just aren't having repeated thrombotic events that are amenable to intensify platelet inhibition until longer term? Maybe it's like a chronic therapy trial, like a statin trial, where we know that you have to accrue time on treatment before you'd see a benefit.
So you follow up average of 17 months?
Yes.
From 12 months to 17 months, at this sort of slightly artificial landmark analysis, you found a trend to benefit, and I think in 1 or 2 the components of the MACE, a significant benefit in the components, favouring Prasugrel from 12 months out to 17 months. Have I got that correct?
That's correct. They were post hoc analyses.
Yes.
They weren't pre-specified, so we interpret them cautiously. But it's an interesting finding. And the other thing we did, which was pre-specified, was looking at all ischemic events, so repetitive events in a given patient, and we did show evidence after 12 months of a treatment response. So
that was pre-specified.
That was pre-specified, but the landmark of the main outcome was not.
That was an observation.
So I think we say they're hypothesis-generating findings. They're not definitive. The trial itself didn't meet its primary endpoint, but it begs the question of, how long should we study these types of drugs in patients who are medically managed? We think, typically till now it's 12 months and we stop. But 12 months is an artificial time point to stop, and the risk doesn't just turn off.
Yeah. So, but before we finish, because I think it's an important point, it was pre-specified that you were going to look at cumulative ischemic events. Now, I wasn't quite sure, and we've discussed this also, what this actually means, and I sort of know what your answer is, and I'd be quite interested to hear, for the audience to hear it, because what I think it meant was that you were looking at patients who had MI and a stroke and revascularization. Is that
something? Yeah, I mean they had more than one event.
Yeah.
They survived their first event if they're going to have more than 2 events. So their first event wasn't cardiovascular death if they're going to have more events. And in some cases these patients may have repetitive events, and they ultimately may lead to a death later on that wouldn't be captured in a time to first event analysis. It may lead to more morbidity, and we have a cost comparison analysis. We'll look at this and how this assesses it. But we know these patients infrequently crossed over to revascularization. Less than 8% did. So their therapy didn't change when they had an ischemic event for the most part. So maybe this means something, and it's intriguing.
Yeah, it's intriguing. But we will see some more analyses.
Yes.
And one of the messages that came out is that this more potent antiplatelet agent will significantly reduce the events in those that have more than one event. Is that,
yes.
Is that
yes.
Okay? So we come sort of to the end of this, and I'm a clinician, a lot of clinicians looking at this, and we'd like to know what you think about how this may change practice. Are there subgroups in there somewhere where this drug for medically managed patients, high-risk medically managed patients, would be applicable? Are we going to hear that from you?
We will have further analyses to investigate subgroups. We also have a large platelet function substudy that will be presented at the AHA sessions, where we'll evaluate serial measurements of platelet reactivity on about 25% of the patients with time. So I'd say stay tuned. I think with the initial results, you can't say that you should recommend using Prasugrel over Clopidogrel for a medically managed patient. you can't say in the initial results that you should use it for more than 12 months, but say, let us do some more analyses, let us sort through some things, and we'll see what it means and how that may change practice. So I think let's take a pause. We'll do more analyses. We'll have things coming out soon, and we can maybe talk in the future.
Yeah, I have to say I've genuinely found this study more intriguing, more interesting, asking more questions than many of the others who have been positive or negative. So very grateful that you've come in, and I've really enjoyed our discussion. Thank you very much, and we look forward to chatting in the future.
Okay, thank you.
Thank you very much, and I hope you've enjoyed the program.